Dr. Sanjay, it is such a pleasure to have you here on the Energized podcast. And I feel like we've already had an interview conversation before getting started. So many questions. But what I want to start off with is one of the things that, one, your humor. I love your personality. I love your humor.
Tell my
I hope
kids
we
that.
get some of that today. I'm sure we will. But that you are a deeply compassionate, functional cardiologist.
Yeah.
And, meeting you, seeing the approach that you take with your patients, the way that you educate, I'm so deeply inspired. I'm excited to get into this because my women, many of them are in that zone of vulnerability where things are shifting. And those silent shifts are not being picked up by their doctors, but most especially their cardiologists.
Yeah, no, absolutely. And first of all, thank you for having me. It's so exciting and I'm energized to be here. I was so glad when I saw you pop up on my schedule. I'm like, yes, we're going to have an awesome conversation today. But yeah, functional cardiology. I don't think most of us start out in the functional medicine world thinking that we want to be functional because we don't really know what that is, or at least at the time when I went to med school, functional medicine meant absolutely nothing. But I was an interventional cardiologist. I guess I'm trained still as an interventional cardiologist. So I was the heart attack doctor, the gentleman that got paged at 2 a.m. when you came in with chest pain and, lights and sirens blazing, come in, get that artery open, fist bump, chest bump, high five. We're super excited. And I did that for about 15, 20 years or so. And then after a while, you start to get repeat business, right? Repeat customers. And when you watch Shark Tank, they ask, what's your repeat customer rate and all that stuff, which is great if you're selling t-shirts or whatever it might be. But in cardiovascular medicine, repeat business means somebody's had a second cardiac event, right? And that's not necessarily a good thing. And so as I got to that 10, 12-year mark in my practice, I was seeing patients come back with second or even sometimes third cardiovascular events despite everything in the conventional system that we're throwing at them, meaning getting their blood pressure under control, getting blood glucose under control, meaning their blood sugar, getting their cholesterol, whatever, blood pressure, blood sugar, and cholesterol. Those are the big three, right? So despite optimal control of these, people were still coming back. And I realized, boy, there's got to be something more going on, right? And this is the burden of, I think, the interventional cardiologist is we're always trying to figure out what can we do to help this person. And I realized that it wasn't just stents and balloons and medicines. There was so much more going on. And in a super backwards way, I fell into functional medicine. I wasn't looking for it. It's almost like, there's that when the student is ready, the teacher appears kind of moment.
Or usually when you've had your own health issue.
Right. I mean, luckily I didn't have my own cardiovascular event, but I kept seeing people coming back again and again. I'm like, man, something is wrong, and we would have these limp recommendations of, well, eat less and exercise more, whatever the hell that means. And, this was just at the time where people like Mark Hyman and others, Peter Attia and others were coming into more popular culture. And then I realized, that might be something I need to look into. So I went to an IFM, Institute of Functional Medicine conference, and realized that this is the answer that I was looking for, is that yes, you do need to still control blood sugar and blood pressure and all of those things, but we also have to talk about the mental, emotional, spiritual aspect of our patients' lives, because we all know that stress is a killer, right? We need to talk about sleep. We need to have an intelligent discussion about diet and what that means. And we need to think about hormones too, because hormonal health is so central to cardiovascular health. And that is just not something that we talk about in cardiovascular training.
No, agreed. If you had an opportunity to intervene, what age would that be for your patients? In terms of when would you like to maybe thinking about their cardiovascular health?
Yeah. So, there's two, when you look at the epigenetic, genetic kind of clocks of aging, two pivot points are at age 44 and at age 60, right? Those are seen again and again and again. And so I really want people to start thinking about their cardiovascular health earlier than that, though. I mean, because this is a cumulative thing, right? So it's like, well, I'm going to treat the car accident when I get into a car accident as opposed to not driving through a red light, right? So we want to be much more preventative and realizing that the cardiovascular disease really starts when we're born and progresses. Now, the rate at which progresses is different for different people, depending on your risk factors and hormone profiles and things, but that's really when the clock starts. So I think once we start to hit 35 or so. And I know that seems super early, but that's when we really need to start thinking about optimizing cardiovascular health, checking lipids. I'm not saying you need to go get stress tests or CT scans or anything at that point, but really just having an insight into not just cardiac health, not just cardiovascular health, but I think more importantly, cardiometabolic health, which really drives a lot of what we see in cardiovascular medicine is this insulin resistance and all of these other associated conditions that happen, low vitamin D, all of these things play a role. And, it's probably to your listeners, it'll sound a lot like a broken record because when we talk about cardiovascular health, it's the same thing that we talk about for hormone health. It's the same thing we talk about for autoimmunity, but it's just difficult to do, I think. And it's not in the sense it's difficult, it just requires work, right? And a lot of times it's just easier to take a pill than to walk 7,500 steps a day, right? I get it. But if you want lasting health, that's really what we need to do.
Mm, agreed. I want to reverse engineer the timeline because I know a lot of women, even in their 40s, they'll go to their cardiologist or even go to their primary doctor looking for more advanced cardiovascular testing, and they'll be told no. Even myself,
Yeah.
I can run my own panels, but occasionally I'm always just curious.
Yeah.
When I go to my primary, I'm like, can I get an ApoB? Or I'll list out a couple and they're just like, it's not indicated. And I was like, well, isn't that the point that we should be looking at these numbers early as a preventative? And so if you could wave a magical wand in
Yeah.
terms of the timeline, let's say 35 is the start. What would we be looking at 35? What would we be looking at in our 40s and into our 50s so that we can be more prepared? Particularly, I also want to spend a little bit of time on that perimenopause kind of transition, that moment, what I call the zone of vulnerability, and what we can be looking for, not only in terms of our cardiometabolic risk, but also even identifying if we're in perimenopause or not. So
Yeah.
I know it's a big question, but I love
I
that
mean,
timeline.
there's a lot there, but I think it's important. Number one, it drives me absolutely crazy, right? When you've got an intelligent patient asking for labs or a test and a physician says no, it's not
Mhm.
indicated, right? I mean, I get it, right? We don't want to be doing inappropriate testing and all that stuff, but particularly for blood work, if you're going in for a blood test, why not just add
Add,
cardiometabolic
add a
marker,
couple
right?
more.
It's literally just one other tube of blood. You're not irradiating somebody or, making them jump through rings of fire or anything like that. So, I think that in terms of tests that you can get early, let's say in your 30s, I think number one, certainly, and most women might have an oral glucose tolerance test from pregnancy or not, but at least some assessment of insulin sensitivity. So that would be, if we're not doing an oral glucose tolerance test, which is, kind of a gold standard right now, even just doing a hemoglobin A1C and either a fasting insulin level or C-peptide. C-peptide is this when you get like a new electronic and you have that little plastic pull tab that you pull out and activates the battery. That's kind of what C-peptide is for insulin. So it's this little on the carbon terminal, the C-peptide, it gets cleaved off and activates insulin. So if you have a high insulin level, you'll see a lot of the C-peptide. And one of the things that I think conventional medicine doesn't realize is that you can have normal sugars, but if it takes 10 times the amount of insulin to get that normal sugar, well, then you're already insulin sensitive. You're already insulin resistant, right? So we have to start thinking about this a little bit differently. So early understanding of your glucose dynamics. Number two, I think there's a relatively new marker. We've known about it in functional medicine for a while, but it's just now kind of wafting into conventional called LP little a. And there's so many of these LP this and that, right? So it gets pretty confusing, but LP, and then it'll be a parentheses lowercase a, is a newly described, I guess, newly in the sense of the last 25 years, described protein that exists on the LDL cholesterol particles that makes it much more atherogenic. So I tell people it's like when you see somebody with tattoos on their arms, but then they have a face tattoo, right? Like that's a different level of commitment,
That's
right?
yes.
When you have
Or a neck tattoo, like
or like teardrop tattoos. That's not somebody you want to mess with, right? I grew up in South Side of Chicago, so I know. But LP little a, when that's elevated, is a really aggressive genetic marker of cardiovascular risk. And it's remarkably elevated in populations like up to 50% in African Americans and certain Hispanic populations. So it really, when you have an elevated LP little a, number one, it's genetic, so it's with you for life, right?
yeah,
So So if you're going to check it, why not check it when you're
Check it
30
early.
years old as opposed to when you're 60 years old? Because that's
Mhm.
30 years where we could have been aggressively modifying it. There are a few medications right now that are in phase 3 and soon to be released that can directly treat Lp(a), but otherwise what you can do is optimize diet, optimize lifestyle, optimize sleep, optimize, your visceral fat and all these different markers that we do in the functional medicine world to reduce that risk as much as possible. So in the early stages, I think some marker of insulin sensitivity test, Lp(a) certainly, and then I do think that at that point, just a regular lipid profile, fasting lipid profile is appropriate. You mentioned something called ApoB, which is great. First of all, let me just say that it's probably one of the most inexpensive tests that you can run. I think when you're cash pay, it's anywhere from $7 to $15 is what I've seen. So it's not an expensive test, but what it does do is it gives us an idea of all of what are called the atherogenic lipid particles. So in the traditional panel, you get HDL, which is high density lipoprotein, which is the quote unquote good cholesterol. You've got LDL, which is the quote unquote bad cholesterol. I have a whole other thought about that. But then, and that's what we were able to test in the 1980s when these tests came out. But now
40
we've
years ago, people. 40 years ago.
I mean, these were really found in the 1970s, and then LDL, HDL, all these things became more mainstream in the 80s. Yeah, so it's about 40 years ago, which sounds a lot longer ago than it feels. But
Yeah, well, let's be honest, because
but
I'm not gonna say we all know how old I am, so
I mean, as my kids kind of told me, Dad, you were born before Google, and I'm like, yes, that's that.
yes,
To them, that's
absolutely
ancient.
born
Might as well
before
have been.
Google.
Yeah, my first job was working on the pyramids in Giza, but that was a summer job. But the point being, in terms of tests that you can get, ApoB is now a marker. So in between HDL, the good cholesterol, and LDL, the bad cholesterol, quote unquote, there are all these other cholesterol particles in between that contribute to atherosclerosis. The only problem is when we did the initial trials in the 1980s, we didn't have all those markers, right? So we didn't know. So ApoB is a cell surface protein. It's a marker on all of these other little cholesterol particles that really gives you a better idea of your atherogenic risk. So if you're getting a cholesterol test, I would absolutely, for your listeners, absolutely insist on getting an ApoB. Unfortunately, most of the cardiologists may know, some of the primary care docs might not know, but I think it's an important enough thing to get. And what we're seeing in the cardiovascular literature is ApoB levels are much more predictive of cardiovascular events than LDL levels. And what we can also see is statins, which everyone has feelings on statins, but statin drugs can reduce LDL, but not reduce ApoB particles.
Mhm.
And so as a result, you think you're doing a good job, but you're not doing what you're supposed to do, right? So I think certainly ApoB. Then getting back to the timeline, then as we turn into our 40s, this is where it gets a little bit interesting because I tend to, and my patient population, I practice in Orange County, California, so I've got a lot of worried well people. And so this is when I'll actually like to do some sort of a CT-based imaging of the heart, not a calcium score, because I don't think calcium score is, it's like bragging about black and white TV at this point. It still has some benefit, right? You can still see the picture and the outlines, but we had
Not enough.
8K screens. And so now we have these CT angiograms that allow with post-processing for plaque identification and plaque characterization, meaning not just how much calcium do you have, but how much soft plaque do you have, how much vulnerable plaque do you have, all of these different metrics that really become much more important in terms of risk stratification, because now we're employing what I kind of call precision cardiology, because in the once upon a time days, I would take your age, your blood pressure, your cholesterol, boop, 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 put it into a computer, and it would spit out some risk, but that's based on populations of basically old white dudes in Framingham, Massachusetts, which is where that data set what came from. But what we can now do is say, all right, you know, Mrs. Smith or Mrs. Jones or, whatever your name is in my chair, this is what your heart looks like. These are what your arteries look like. Number one, it can be kind of jarring to see that. But the number two, now we need to do these risk factors or maybe use these medicines for a certain period of time or these supplements or whatever it may be based on a risk profile. And I think it becomes really important. Now, in women, you have the breasts and things, there. So I don't love irradiating tissue unless we need to. But, I think it's a reasonable thing in the right patient population. If we're concerned, then you can always do ultrasound based, like a carotid scan, so there are other ways around it. But I really do like the use of that CT angiogram because I think rather than getting, a crappy test every year in terms of like a stress echo or something, now we're getting clear images of what the heart looks like. And at that point, I think in your 40s, an advanced lipid profile that's really diving deeper into the numbers. So this is where it gets a little bit nerdy, but beyond just the LDL concentrations, looking at particle numbers, particle size, markers of vascular inflammation becomes super important. And really that decade of 40 to 50, I think I like how you say it's that vulnerable critical window, because that's when the 1% changes that you make at that point will pay huge dividends when you're 60 or 70 years old, right? It's like contributing to your 401k in your 20s, right? Like $200 doesn't seem like a lot or whatever, but when you're 65, you're now retiring a millionaire or whatever, depending on how well you invest, because you made those small little habits, those little changes. And so that decade of the 40s becomes super important, particularly because in women, that's when perimenopause starts to happen, right? And so I kind of think of estrogen in terms of cardiovascular risk. I was sharing this before, as like a nice blanket protecting you from cardiovascular risk. And as the estrogen level starts to deplete and the hormones start to fade away, it's like that blanket gets pulled and now your feet are coming out from underneath that blanket. Now your toes are cold, right? Well, that toes being cold, that's your cardiovascular risk kind of creeping up on you. And so it becomes really important to engage in those lifestyle diet habits, which are certainly there, but also then to think about, hormone replacement. Because as I see it, hormone replacement is as much a life-saving measure as telling someone who's 40 years old to stop smoking, because there is a cardiovascular risk associated with smoking, as there is a cardiovascular risk associated with that drop in estrogen. And I can't remember if you asked it or not, but I'm just going to put it in anyway, is that cardiologists oftentimes, or maybe not just cardiologists, but anybody checking a lipid panel often has frontline access to when perimenopause starts, because we'll see someone whose LDL cholesterol has been beautiful, 80 to 90 for years. And then all of a sudden you see this bump, right? It bumps up into like maybe 106, which is really still not that high. But when you start out at 80 or 90, that's, a 15 to
It's a
20,
bump. That's a 15-point
right?
bump.
It's so in relative,
Especially if you change nothing.
especially if you change nothing, right? And that's the problem, is that cardiologists for years, and I'm guilty of this myself before I had my awakening into functional medicine, but I would say, hey, you know what? You're doing something different, eat better, exercise more, right? The same, party line that we used to say before. But now, as kind of in this more integrative functional space, I'm realizing, that's the canary in the coal mine. That's the first sign often that we'll see of that drop in estrogen, is not a hot flash, not my hair falling out, none of these things that we associate with perimenopause, but that little bump in LDL. And that's when we need to start thinking about getting hormones tested and, seeing a menopause specialist and perimenopause and all that stuff. So I think more so than men, because men don't get that bump. We just have high cholesterol out of the gates, right? Like I've had high triglycerides since I was born. But women, when you see that shift, right? I mean, that's just bad genetics. I wish I could choose better parents, but I don't have that luxury. But in terms of cardiometabolic health, better parents. But, in women, we see that acute shift. And that's really when we need to start thinking about it and intervening. And I can promise you, I'm probably one of this many cardiologists in the country,
Thinking about
that
that.
think about it that way. But
Mhm.
that's the work that I do within my cardiology circles now, is really exploring that and having my colleagues in the cardiac universe realize that bump in LDL is not a cute little, oh, how cute. That's actually,
No, that's
that's
an
a warning
indicator.
sign. That's a orange flag, if you will, of, the ghost of cardiovascular risk future. And that's the time to intervene.
Mm. This really points to the importance of a timeline as well.
Yeah.
Not only as a cardiologist or a primary doctor, but really, I mean, we live in a time where still a lot of doctors aren't catching this. So, as a patient, it's really important where you're looking at a timeline of labs since you were 35 years old, or maybe at least 40 years old,
Yeah.
and everything looks good until it doesn't.
Right.
And this is what I've, as a practitioner for a very long time, I've been looking at these timelines and I will see that moment, whether it's 43 or it's 45, maybe it's 47, where something shifts.
Yeah. And you're
And
like, what happened in September of 2023? Right? Like you can see it on, now that we have these electronic medical records where you can graph out things,
yeah,
you see this line, and then a bump.
then
And you're
this
like,
bump.
oh,
Yeah.
what happened there? Oh, that's when, my life got stressful and, this
Or
happened. But you can pinpoint these times, and it's pretty remarkable to be able to do that.
No, and that's why I really wanted you to point that out, that we were discussing that beforehand. But I think the more of us that are talking about that, the importance of us women having their own timeline of labs. And obviously doctors, that it should be, the onus should be on us, the doctors, but it's just not where we're at yet, not in
And
conventional medicine.
And I always tell patients, I know what I know, but I don't know you as well as you know you, right? And this is, I think, where doctors in my conventional universe, in our conventional universe, I guess, kind of fail in the sense that they will gaslight people into thinking, hey, your labs look normal. I don't know what you're talking about. Everything, you should feel fine, right? How many times have listeners heard that? You should be okay. Like everything looks fine here, right? But something is not, right? And in this day and age where there are, I don't want to call us alternative doctors, but there are more informed doctors, right? Kind of higher, like elevated doctors that kind of understand this, come out and reach out to one of us. I'm sure any of the guests on this podcast before me or after me will be one of those doctors, right? Like, but find someone who understands things and looks at things a little bit more holistically, because oftentimes, what I've found is it's not always a medical issue, but it can be an emotional issue. It can be a mental stress, and particularly I think for women in that perimenopause age group, I call it the caregiver sandwich, right? You're getting it from the top and the bottom because you're taking care of aging parents. I mean, call it what it is, but in our society, women tend to take on that role, right? So you're dealing with your parents that have always been crazy, right? And now they're not listening to the sage advice. And I don't know if you get this, Mariza, but for me, like I am a physician and my parents listen to crap on WhatsApp that their friends send them more than they listen to me, right? Like I'm like, oh my God.
Yeah, a lot of family. Luckily, my mom, we were talking about her earlier and how she really has always taken my advice and is thriving as a result. But we were just having the hormone replacement therapy conversation who at 65, and she just got a DEXA scan and we saw a little bit of osteopenia in a couple areas. And this is a woman who runs, trains, plays tennis. And I was like, listen, the greatest intervention that we can bring in on top of everything that you're already doing is estrogen.
Yeah.
Like, it's time.
Good for you. Count your blessings that your mom listens to you. I mean, that is not the normal,
No, I know it's not the norm at
like
all.
they will find everything else and they'll talk, spend millions of dollars on supplements before they realize that sleeping an extra
Oh,
half hour is really what they need, right? And then so you're taking care of that generation above, and there's a lot of emotion and stress tied into that, right? You may be battling with siblings about who really takes ownership. And so that's a whole triangle up there. But then you've got the triangle of your kids and taking care of them and then balancing work. And you're just like in the middle of this, of this disaster diagram where all arrows point to you. I mean, I think of that Calgon Take Me Away commercial from, the 80s. I'm like, man, those guys had it right. That commercial hasn't aired for like 40
they,
years.
they nailed it.
And that woman, I just get her, right? Like, and probably a lot of your, if you don't know, if you've never heard of Calgon Take Me Away, I'm sure there's a commercial on YouTube or something. Like, it's this woman who is just exasperated and all she wants is like 2 minutes alone in a bathtub, right? And she just can't even get that because the husband is pounding on the door, or the kids, you see the little fingers under the door jamb or whatever. But that level of stress really is the cause of so much cardiovascular kind of manifestation, so you add the stress on top of hormone changes, on top of all these different things, it's amazing that we live past 40, right? I mean, we are very resilient, I guess, as humans, but we have awareness now of all these things,
Yeah.
right? Now, we can live better into our 80s and 90s and hundreds, perhaps even if you're so blessed, by taking care of a lot of these 1% changes, like I said, in our 40s.
I so appreciate you talking about the silent shift. I often, what I'll hear, even from conventional OB-GYNs or doctors, is that this zone of chaos, perimenopause and menopause, the symptoms are you're just going to get through this time of chaos and it's all just going to kind of fade out. And I'm just like, what about the silent shifts? What about the cardiometabolic risk that we just stepped into? Like, why aren't we talking about this?
And this is, I say this a lot, is nobody dies from perimenopause, right? I mean, like you feel like you're going to die, right? I'm not like insensitive to that, right? Nobody dies from menopause, but you die from the consequences, right? You're dying from the cardiovascular issues. You're dying from the complications of the metabolic issues. So we really have to treat perimenopause, like I said, as a risk factor as aggressively as we treat smoking, right? Or, I mean, when was the last time you got into a car and didn't wear a seatbelt, right? Never, right? Like we need that level of just automatic treatment for this, right? And I think in the government we've now seen shifts, right, where we're kind of green lighting hormone replacement a lot more. I think there's a lot more awareness certainly now than 10 years ago. Imagine 20 years ago, right? I mean, like, so I think that the awareness is there. Now we just need to let it filter down into the practitioner level, those primary care, you know, physician assistants, nurse practitioners, MDs, DOs, whoever it is that you're seeing your naturopaths, whoever you're seeing your care from, right? Like, we need to realize that this is not something that women should. I mean, it's not. What's the best way to say this? Is it's there's no gold medal for suffering through this period of your life without hormone replacement because it
Let's
puts
talk
you at
about
risk
that.
for death, right? I mean, if somebody's cholesterol is high, I'm not going to say, let's not do anything about your cholesterol. That's just normal aging, right? That would be stupid. I'd have no repeat business because everyone would die, right? In my practice, right? But we need to change that conversation. I think the mindset, both of the patient and the practitioner, because there are certain women, and I see this a lot in my older patients that are said, well, I never needed hormone replacement therapy. I never had a hot flash in my life or whatever. First of all, I want to call it BS because I don't think that's physiologically possible. But if you did, great for you, but there's still risk, even if you didn't have all that happening, that you can be shielded from with appropriate therapy, right? You might not need as high a dose. You might not need to cycle. I mean, I'm like a hormone idiot, so I'm happy to send to people that know more about this, but at least I know to send when I need to for that, right? And so we just need to change this conversation. Well, I don't need to put a seatbelt on because I'm just going down the street. No, you need a seatbelt because you're in a car, right?
Yeah, you're in a
And
car, and
you're in a
the
car,
risk,
right? And
the
and
risk
you don't need
factor
to
is
be on
great.
hormone replacement because you have symptoms. You need to be
Yeah.
on hormone replacement because you're in perimenopause, menopause, right? And that's luckily we have the technology and the medical know-how and the medications to get you through that, right? Bioidentical and all of these things. So why not use it, right?
Well, I think we're moving away from thinking about hormone replacement therapy as symptom management and
Yeah.
only symptom management, that it's about optimization, it's about longevity, and ultimately pointing to good cardiometabolic health. And if we can be on the preventative side of that, particularly in perimenopause, before symptoms really become an issue or those silent shifts start to play out, we are winning the game of health span and longevity.
I mean, it's like a time machine, you know what I
Yeah,
mean? So I remember I
exactly.
said that cardiovascular disease starts when you're born, right? And that slope depends on what you do, right? So if you are an exerciser, vegan, whatever, all that stuff, that's a very different slope than someone who smokes and drinks a 24 pack of soda a day, right? And so we want to maintain that nice, slow, even cardiovascular risk profile. And that's just one of the tools that we have available to us.
Hmm. I want to move into accessibility because I always want to feel accessible to anyone listening to the show. And so we talked about labs, and I feel like a lot of the labs that you talked about, Dr. Sanjay, are very accessible, or even out of pocket. We can get
Yeah.
those. Are there other labs that, if we were really struggling to get them, like something I always tell my patients is like, the poor man's fasting insulin, which is so ridiculous that we would even need to have that conversation. But basically, dividing triglycerides over your HDLs, just
Ratios, yeah.
again a proxy of looking at, are there, when we're looking at, if we only had a standard lipid panel, can we glean information from something like that?
I think that certainly looking at triglycerides is a risk of metabolic disease. So the HDL to triglyceride, or triglyceride to HDL ratio rather, is a marker of metabolic health, certainly. It's as we get a little bit more esoteric, I think, first of all, I don't think ApoB should be considered an esoteric lab. I think it should be a standard lab. But the point is, if you see a huge discrepancy between ApoB and LDL, right, that tends to mean that you have a lot of what are called the small, dense LDL particles, the more atherogenic particles. I call them the small and stickies.
Yeah.
They're the ones that have been metabolically damaged. And so they're just angry. They've got teardrop tattoos on both sides and
They're just sticking.
they're just shoving in to the arteries. And part of that process of metabolic disease is that there is a layer on top of the cells of the blood vessel called the glycocalyx, which is now recently described. And what we see is as you get metabolic derangements, that glycocalyx starts to dissolve and disintegrate. And then just like we talk about leaky gut all the time in functional medicine, now you get leaky vessel, right? So now when you've got elevated blood sugars, your blood vessels are now more prone to atherosclerosis. at that same time, you're getting these damaged LDL particles that are activating the immune system. And so they want to get shuttled. Your body just naturally wants to shuttle them out of circulation. And how does that happen? Well, it pulls it into the middle layer of your vessel called the media and forms a plaque, right? So it's this whole feed forward cycle. On that note of the glycocalyx, one of the most interesting things that I've seen in terms of perimenopausal women is that in the smaller branches of the blood vessels, what are called the arterioles, you see preferential degradation of that glycocalyx. And so a lot of times women will get these weird chest pains or shortness of breath symptoms in that perimenopause state. You do a
Yes.
stress test, it's completely normal,
Mhm.
but the small kind of microchannels are ones that are affected. And there are a couple of supplements that I put people on. Like I had a woman that had seen every specialist in Southern California for her shortness of breath. And somehow I run a metabolic program. So she fell into my metabolic program. And within 2 weeks, she was like, "Oh my gosh, I can walk again and I can take my kids to their soccer games," because the conventional world didn't realize that she happens to be overweight and she happens to have, risk factors and all this stuff, but she also happens to be a perimenopausal woman with normal epicardial coronary arteries, meaning normal big arteries. And it was just a no-brainer for me to say, "All right, take this, nitric oxide supplement and this glycocalyx supplement and see what happens." And it turned around so quickly, right? So
I love that. And the reason why I want to put a pin in it really quickly is so often I've had patients come to me with palpitations, shortness of breath, and they get a workup. They're fine, they're normal.
you know what it is? 9 times out of 10 in my practice, progesterone. I just had a woman that went through this whole $1,000,000 workup for palpitations, and I said, "Hey," when she was she's 40, in her mid-40s, whatever, 44, 45, call her, and the first question I asked was, "Were you on hormones at all?" And she goes, "Yeah, how did you know?" And I said, "Well, what happened?" "Oh, I stopped it a few weeks ago. I forgot to pick up my prescription, and so I was off of it for a couple of weeks." And I was like, "And how did that," and patients will oftentimes not see that link. And I'm like, "Oh, and when did you start feeling those palpitations?" "Oh, maybe a week or so later." I'm like, "Well, let's just before, and I had inherited her from all these other places, but I'm like, let's just, before we do any other tests or put you on heart monitors, let's just get you back on the progesterone and see what happens." Right. And sure enough, she felt better. Right. And in a previous life, before I got into cardiology, I was doing research on the effects of the pet hormones, as we're supposed to call them now, right?
Yep, no, the pet
Not
hormones. Oh
sex
my god.
hormones, but the pet hormones
That's my
on
short tea, everybody. It's just for
what's that?
progesterone, estrogen, testosterone. If the audience probably doesn't know what
Oh,
that we're changing it
I
over.
got reprimanded by one of your colleagues for saying sex hormones. We don't say that anymore. Not really, but
I just think, why can't we just keep it HRT? Why does it have to be anyway?
whatever. But these pet hormones, progesterone, estrogen, testosterone, actually directly affect ion channels inside the heart. So the sodium, potassium, calcium shifts that lead to our heart beating are affected by the levels of these hormones. So yeah, if you abruptly take one away, you're going to
You're gonna
feel
feel
kind
that
of funny.
shift.
And whether you do that through withdrawal of hormone replacement or naturally dealing with perimenopause, menopause, yeah, you're going to feel some cardiovascular symptoms. And that's why, if I had a magic wand and I had this call to action, I think one of the first things that I would want to do is in the cardiology community, get my colleagues much more conversant with at least testing for hormones. Maybe we're not the replacers, right? But at least get them tested, because a lot of times when we're dealing with the female patients that I see, it's these vague symptoms. And we do the same,
You're
useless
good.
workup. We'll do an echo and the, ejection fraction is normal. We'll put you on a treadmill and that looks okay. And we'll put you on a heart monitor. We might see an extra blip here and there. And people will, oftentimes the response is, well, drink less wine or have less coffee or don't exercise as much or exercise more. I mean, it's just nonsense stupidity, right? But the real root cause, right, is that new hormone shift that's happened. And that's the root cause. That's what we need to address.
Hmm. This is just so enlightening as people are listening right now, just connecting the dots, because it's these aha moments of just like, oh my goodness, I'm always recommending to my patients, like, well, in terms of accessibility, lab markers to be looking at, signs to be looking at, all of this, so that even if your provider's not listening, even if you're not, your cardiologist is giving you a workup and you're like, oh, but you're normal and you're back into the world again, these are the interventions that you can begin to bring on.
Exactly, exactly. And I mean, if we want to get deeper into the realm of blood works and tests and things like that, we certainly can. I mean, there's markers of vascular inflammation and markers of, too much meat in your diet and kind of all of these things. But a lot of times the answer is just staring you right in the face if the doctor asks the right questions, right? You don't need
Mhm.
a million, and they teach us all that on the first day of med school, right? Is, the patients will always have the answer. You just have to ask the right question.
Yeah, it's all about that that health history. It's
Yeah.
so true. It is so true, and I do deeply appreciate it. I know we went over some labs. Are there for you, as a cardiologist, as a functional cardiologist, gold standard labs you would love to see? I mean, hormones are a big part of my panel that I always want to just look at, especially if a woman's in her 40s in midlife. But also, I want to look at inflammation markers. I always want to look at fasting insulin, or if I can get a glucose tolerance test done. Like, these are the things that I'm looking at because I think about insulin being a massive risk factor for
Huge.
cardiovascular disease.
Well, and not just cardiovascular, but cancer, right? Like breast cancers and all sorts of different things, right? So, like in terms of the master list of meds, I mean, certainly, or of labs rather, your basic chemistries, make sure your liver is okay, make sure your kidneys are working fine. So that would be, easy to do. Complete blood counts, anemia, thyroid, I think becomes hugely important. People don't realize the link between thyroid disease and cardiovascular symptoms. Either too high or too low thyroid
Right. Oh,
can
yeah.
affect your heart, right? So that certainly is something. Metabolic labs, so hemoglobin A1C, I like a fasting insulin if I can get it. If not, C-peptide. C-peptide has a rather short half-life, so you have to be careful to know when during the day you
When you're
check it.
testing. Yeah.
Yeah, when you're testing, I like to do it maybe first thing in the morning just to get
I like
to
to
get
run
that.
all labs ideally first thing in the morning.
Yeah,
Like thyroid labs, lipid labs, fasting, insulin, ideal. I mean, I think the earlier we can, there's less adaptation that's happening throughout the day.
I mean, the water's less muddy,
Exactly.
right? It's a better example of your resting state. So in terms of endocrine labs, so thyroid certainly, I mean, all the, but depending on the right patient, progesterone levels, estrogen levels, DHEA, all of those things. On the more cardiovascular side, yeah, I mean, I'm a lipid nerd, I guess, so I love advanced lipid profiles. I really kind of nerd out with those. And so that would just be beyond the total HDL, LDL, and triglyceride numbers, looking at the actual numbers of particles, the particle size. Once upon a time, they used to give us these graphs called a histogram of what the distribution looks like. So
I've
sometimes you
seen
can have
those. Yeah.
a normal, I mean, this is where I kind of go crazy, right? But you can see a normal calculation, but you have a bimodal distribution. So you have a bunch of really big ones and a bunch of really little ones,
Yeah.
and the average is in the middle, but that's certainly not normal, right? And so looking at that, markers of vascular inflammation, I still like those a lot. So myeloperoxidase, high sensitivity CRP, another one that's different from LP little a called LPPLA2, which is a marker of vascular inflammation. A little bit more, there's a little bit of controversy there. Oxidized LDL is another one, which is
I don't see that often.
damaged the
Yes.
damaged LDL particles, or sometimes you can even get a number of what are called SD-LDL, small dense LDL, and these are all part of an advanced lipid panel. Right?
This is
You
again,
don't
you're going to
you
have
don't
to
have to
ask for an
order these. You don't have to
advanced
order these
lipid panel.
individually, but you can look at them all together. Certainly, LPA. There's a new emerging thing called oxidized LP little a. So if you thought LP little a was bad, damaged LP little a is even worse. So that's coming out quite a bit.
I'm also asking ferritin, ESR,
Yeah.
homocysteine,
Yeah, oh,
and those are
homocysteine
typically based
homocysteine uric acid, I put those together
uric
as well,
acid.
right? Homocysteine is a marker of methylation and certainly independently associated with cardiovascular risk. David Perlmutter's book, Drop Acid, brought wind to the importance of uric acid, and I really see that as a marker of oxidative stress,
Agreed.
so your cells are off, so I don't it makes for a sexy book title,
It
but
definitely does.
I mean, when I saw Drop Acid, I'm like, "Yes! Not what I was thinking it was about," right? But the point being is that, we have these now relatively standard tests that we've done, like uric acid, for years that now look a little bit different. For toxicity burden, I like looking at GGT just as a screening, because people don't realize how much heavy metals we take on, particularly in coastal communities. If you're eating a lot of sushi and stuff, which I do, I probably got a ton of parasites and a ton of mercury in me, but that's certainly a marker. I mean, I think that is a pretty
I
good
mean, that's
list.
a
And
I
there's
that
ADMA and TMAO and all these other things. I mean, but practically speaking, particularly if like I work in a cash pay practice, I'm not going to order $10,000 worth of labs, right?
yeah.
And in fact, my patients are surprised at how few labs I order because I haven't ordered a stool microbiome test in probably 4 or 5 years because I know when people are out of sync, right? I know when they've got dysbiosis, and I know when they're back to normal, when they're in eubiosis or whatever that right word is. So we just have to be smart about testing. But, somebody's coming to me and they've got a pot of gold with unlimited funds and they're like, let's test everything. All right, game on. Like, let's just check yes to everything that the lab orders and run from there.
I appreciate that. That's why I always want to come from that place of being approachable and having accessibility. And what does that look like? What can we glean? And like you said, how you started in this conversation was that it's really about the right questions. If you've got a doctor who's curious and who's asking the right questions, I mean, obviously labs can help validate what we're seeing, and sometimes, identify things that maybe you didn't know to pay attention to
I mean,
because you've been gaslit so many times.
yeah, you'll get something new from time to time. I mean, I think some of the new cancer check labs are really cool, and screening for all different cancers. I think those are kind of powerful as well. When we talk about longevity, right? The first rule of longevity is don't die, right? So what kills you, right? Car accidents, right? Put on your seatbelt, cardiovascular and cancer, right? Those are, and medical errors, right? So stay as healthy as you can, as long as you can without going into a hospital as part of your longevity play. But there's a lot that we can do. But, just because we have a test doesn't mean you have to order it, so be smart. And just, I think as doctors, we just need to ask the right questions.
Mm. I agree. This is going to be more of a general question, but in terms of, taking care of patients for well over 20 years, let's say you do start to see kind of early cardiovascular risk. You start to see changes in lipid profiles, you start to see more kind of oxidative stress developing, more inflammation developing. And then you run a health history and it's very clear that this person is burned out, stressed out, and kind of running on fumes. Sanjay, honey, what would be some of your kind of non-negotiables for a patient like this, a woman, particularly a woman as well? And some things just can't shift. Like she's just in it.
Well, I mean, I think the first thing is addressing mindset, right? Is that I tell people you're the foundation that the entire house of cards is built on. So if you fall apart, everything that you feel depends on you starts to fall apart, right? And so really kind of understanding that self-care is not selfish care, right? It's taking care of everybody around you, right? And I think that's the first part of it. And then you have to be tactical. I'm not going to tell someone to make 137 lifestyle changes at a time, right? We start with, what do you notice? You're tired a lot. Okay, why don't we try to get another extra hour of sleep, right? Turn off the devices at night, right? How many times are you eating fast food, right? I understand that it's tough. Maybe let's meal prep or get a meal delivery service that can deliver in meals if that's an option for you that are healthier, right? I mean, there's alternatives that we can do. You know, happy, like joy, I think becomes super important. Like, when was the last time you did something fun? Like, when was the last time you laughed? And it is humbling when you ask people who are in the thick of all this, a lot of times, like, when was the last time you had a blast and you felt like you were laughing so hard you're going to pee your pants, right? Oh my gosh, it's been like 10 years. Well, you need to have some fun, right? And it's not a lot of these high tech antibodies against IL-6 and TNF. Like, yeah, that's great that we have that stuff, but it's all these low tech things. When was the last time you felt connected to somebody? Maybe there's, a spouse issue and maybe there's not that connection, right? I'm not saying go out and get divorced, but do something to reestablish that connection, right? Have date night where you leave the phones at home, right? Or what? I mean, my key is my car phone or whatever, but so I can't
It's
really.
true. I was gonna say my key is my car.
Yeah,
Exactly. My
but
phone
so
is
that
my
might not
key.
work so well, or be really kind of short picnic in the front yard.
Got it.
But
Technology.
I know, damn it.
Just
But the point is that I think that first of all, start with something that you can do, right? Again, it's 1% shifts. You don't have to change 1,000 different things. But, if you know that your sleep is off, then just aim to get another hour of sleep. Maybe that means you're watching one less episode of whatever you're streaming
Stranger Things.
channel. Yeah, Stranger Things, or what is that, Hunting Family, or what are the Hunting Wives, or whatever is popular now.
I have no
Um,
idea.
I don't know. There's
Is
all
this a
these
reality
Netflix.
show?
I feel like I'm such a pop culture kind of like.
Because you have 16-year-old
Yeah, yeah,
girls.
my daughters point out how little I know about pop culture, but maybe it's the streaming, or maybe, like, I don't want to call my wife out because but maybe it's that late night phone call to your mom where you're always arguing about some nonsense that happened. Like, maybe that phone call doesn't need to happen, right? Like guard
Especially
your,
before bed with
yeah,
your
exactly. Like,
like
guard
that
your
is
emotional state, right? And, maybe it's something biohacking, like wearing blue light glasses and all of these things, but figure out, I think, and that's where a good functional medicine integrative doctor can kind of help, is figure out what are some of those not easy, but maybe low-hanging fruit interventions that can be taken before you're turning vegan, before you're jumping into cold water, which by the way, cold water plunges and I are not friends.
We're
But
not friends. My
yeah, I'm
nervous
not.
system.
It may extend my life by 10 years, but I'm not going to do it. In the same way, I don't eat kale because to me it tastes like soap. So it might be healthy for everybody else. I just have a snip that it doesn't taste right to me. So
Is cilantro
realize
the same thing for you as well,
I
or
love cilantro
okay, I
actually,
love
but
cilantro. Okay.
yeah, so I don't luckily I don't have that one, but my wife has that one. But the point being is you don't need to change your entire life at once, but start to make the changes that are going to make a big difference, right? And I think one of the hardest ones, particularly what I've encountered in my practice for women in particular who probably are part of your community, is the importance of saying no.
Mm,
Right, and defending your bandwidth. I think,
mm.
like, I think of,
With
like, whenever
lack of
somebody
bandwidth.
yeah, I mean, whenever somebody asks me, like I get, can you do this or can you have this meeting or whatever? I always think of that Braveheart scene where he's like, hold, 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 and the horses are charging and they're like,
Hold.
hold, right?
Hold the
And
line.
yeah, exactly. Hold the line, defend your sanity, defend your bandwidth. You don't have to say yes to everybody, right? You don't have to say everything. And I think it was in, the mastermind community that we're part of that I heard, if it's not an F yes, it should be an F no, right?
That is
Like,
the mantra of midlife women right there.
yeah,
In terms of my podcast, because I know cussing, so if it's
yeah.
not a full body yes, it's a full body no.
That's exactly what the
That's
F
what the
stands
F
for.
is.
Yeah, full body. But I mean, I think there's so much wisdom in that approach, right? And just defending yourself again, because nobody knows you better than you know you, and nobody's going to defend you stronger than you can defend yourself, right? And all of these things are like, I think of those old Tom and Jerry cartoons where he gets shot with a shotgun and drink water and all the water would come out
Come out of the holes.
or whatever. Like every time somebody asks me to do something that I don't want to do, I feel like it's like one of those holes being poked in me. And as I drink, all the water is just going elsewhere and I can't use it to hydrate myself. Kind of a nerdy, you
I
know,
love it. I love
but
it.
I think, sleep, managing your stress, saying no, getting rid of ultra processed foods, but don't try to do it all at once. Figure out, along with your doc or take the time to introspect and say, all right, this is the one change I can make. It may not be the best change that I need, but it can be the thing that I can do. Maybe I can have somebody else pick up the kids once a week in carpool so that I can just have my Calgon bubble bath, right? Like whatever it might be, right? Just make one little change and start to then kind of use that as a foundation to compound these other lifestyle changes.
I love that. We were talking earlier before we got started that lifestyle medicine is mitochondrial medicine.
Yeah.
And I'd love for you to speak into, how mission critical is lifestyle versus more medical intervention here when we're talking about cardiovascular health.
I mean, you can put all the medications in the world into a patient where if the milieu, right, the physiology isn't willing to accept, it's never going to make a difference. I tell people you can plant all the seed you want on your driveway. It's just not going to take, right?
I
And
love
so
that analogy.
yeah, and so, when we talk about lifestyle and all of these things, there's science behind this, right? There's a reason behind this why it's so important because like for hormone replacement, for instance, if you're metabolically out of whack, no amount of hormones is going to fix you, right? Like it's going to be like putting fuel on the fire, right? And
Agreed.
then when we talk about the risks associated with hormones and stuff, as you start to escalate those doses, the risks get higher, so I kind of talk in my programs about, nobody should be on hormone replacement unless they first optimize their cardiometabolic status, right? Like, I think it's so important to get that done. And I don't know if you've seen the same, but in my patients, a lot of times, a lot of those vasomotor symptoms like the hot flashes and things improve significantly once we've got them resensitized to insulin and once we've dropped their visceral fat and all, the visceral fat meaning not the pinchable kind of muffin top stuff, but the internal fat of
Deep.
your organs that likes to suffocate your organs. That stuff is so metabolically active. There's this whole new body of literature on what are called adipokines. I don't know if you've talked about it on the show before, but like particularly in cardiovascular medicine, looking at these adipokines and how they affect heart failure and how they affect atherosclerosis and hypertension and all of these things. And like I've seen it in myself. Now I didn't have a cardiovascular event, but I put myself on my metabolic program I dropped about 25 pounds. My visceral fat, I got DEXA scans because I'm a nerd. So a DEXA scan, most of us know it for bone health, but also one of the
Lean body
most
mass, visceral body
accurate,
fat.
yeah, one of the most accurate body fat assessment tools. And my visceral fat dropped by 60% in the course of about 6 weeks. And my blood pressure normalized and my snoring went away and my energy, talking about mitochondrial health, like I didn't need naps anymore. I felt like energized. And, I was almost drinking my coffee in the morning as a ritual as opposed to
More of a ritual than you needed it.
yeah, I mean, I just like my cup of coffee in the morning, but more of a ritual than I needed to, give me that kick in the pants to get out of the door. So, yes, getting back to mitochondrial medicine and lifestyle medicine, I mean, as we do more research into this world, I mean, the mitochondria are so essential to everything, and almost everything we do in terms of bad lifestyle affects our mitochondria in some way, shape, or form. So if you can just do something simple like sleep, eat, like last night I had a big thing of greens. I don't love them, but I know I ate them because I was, helping
Look
myself.
at you. I love
Yeah,
it.
I mean, I put my money. I was explaining to my daughters how when you eat like one serving of broccoli, it protects your DNA for hours and days afterwards, right? And they're like, Dad,
I was literally having that same conversation with my son
that's
yesterday.
great. Oh, funny.
Yes,
Yeah, I'm
about
talking about
broccoli.
sulforaphane. Not often
Broccoli for dinner.
sulforaphane comes up, but I mean, so many cool things happen, right?
Yes.
And what I really love about what I do now is as opposed to, $1 million solutions for $1 million problems, now I've got nickel solutions for $1 million problems, right? Like we can do this so cheaply and so effectively. And when I see, I mean, I almost feel like it's a failure of medicine when we see these aggressive new antibody against this cell cytokine or whatever it might be, we've lulled people into thinking that you need to have these advanced medicines that cost oftentimes
Oh my
thousands of
gosh.
dollars a month,
Not covered by insurance.
not covered by insurance, and you're going to go bankrupt, right? I mean, the number one cause of bankruptcy in the United States is
Healthcare.
medical debt, right?
Mhm.
So, we don't need to drive ourselves bankrupt. We just kind of have to think of that flow of money differently as, yeah, you know what, that extra money that you spend on organic, produce or whatever it may be, will help you to from having a quadruple bypass later on in life is a big deal. Oh, and you mentioned cilantro. Here's something I learned. Always
Oh,
buy
no.
organic cilantro. Why? Because they actually use cilantro to clean the soil in contaminated, like, so they'll plant
I
cilantro
didn't know
in
that.
between like other crops to get rid of the
Like
toxins.
sop up.
Yeah, if you're eating regular cilantro, you may be taking in those toxins. So I started buying organic cilantro. That was just an aside that popped in my head because you mentioned it.
I mean,
But
we try to buy organic all the time,
I mean,
no matter what. I
yeah, I
mean,
mean,
there's some things we don't buy organic.
my general rule is if you're not eating the skin, you don't necessarily need to buy organic,
Exactly. Like
right? So like
avocados, I'm typically not buying organic
avocados, no way. Bananas, probably okay. Strawberries, blueberries, the dirty dozen or whatever, those definitely you need to buy
avocados.
organic. And, I'm a big fan of knowing the name of the person who grew your food.
I love
So,
that.
meet the people.
We're a little bit privileged in that way, because we do live in Southern
I mean,
California.
I grew up in Hobart, Indiana. So, like, I mean, now there's like a Taco Bell there, but when I grew up, there's nothing. But there was a farmer's market. And I remember, we would go there in the winter and we would just eat whatever, we would buy whatever was available. So we're eating very seasonally, kind of now it's all cool and hipster to do, but, we just did it unknowingly. But yeah, I mean, eating with the cycles of the earth and, Deanna Minnick, if you know her, she talks about this a lot.
I love her. She's about to
Yeah.
come on the show
Oh, she's such a lovely
again.
human. But, I learned that from her and really do try to eat along with what's available. And there, I mean, like I said, I grew up in the middle of nowhere, Indiana. There was a farmer's market. We didn't call it, we just call it the market, right? We didn't know that,
Yeah.
but, there's options and, do your best, right? I think in all of this, a lot of times people get caught up and there's an anxiety about, oh my gosh, I need to do everything right. Yeah, maybe, but you know what? Just do what you can, right? I think accessibility, I think that's the most important thing is do what you can. You know what? I told myself before I had kids, I'm never going to buy them fast food and we're never going to have chicken nuggets in the shape of dinosaurs. Turns out that was their favorite thing to eat, right? And I'm just like, I'm just going to get whatever I can into these damn kids, and fed them
So
the dino
I have not
nuggets.
broken that. That has not been, that's a full body no.
Oh, well, for me, I had triplet. I mean,
I got my
whatever.
son drinking a green juice this morning.
Oh man, you're a better parent than I am for sure. But like, I just, we have triplets and I was like, whatever. Like at
I have
that
no,
point,
I do not have, I have one
yeah.
child.
whatever we can get into you, we'll get into you. And, we just made the substitution. But, on the flip side, they didn't taste chocolate until they were 6 or 7 years old and they got it at school and they got mad at us for why didn't you give us chocolate?
We've had like Q chocolate, like super clean chocolate. Like
Yeah, but
Kingston knows there's a gradient of chocolate out in the world. There's crap chocolate and then there's high quality chocolate. I just have a bougie child at this point in my life. He's just like, is it what brand is that? No, I don't eat that.
no, I don't eat anything less than 70% is not. But the point being is that don't like I don't when we have these conversations, I think it's important to end on if we're ending, but to not feel guilty about any of this, right? Is that just do the best that you can. We're all just trying to get from Monday to Sunday and
Mhm.
repeat, right?
Yeah.
So, do the things that you can do the things that are accessible. Don't, if you're not feeling right or you don't get the warm fuzzies from the doctor that you have, then find another doctor.
Find
It's
a doctor.
okay, right? Like find someone that you vibe with. Like I tell people, you should feel like when you go to your doc, and this is kind of how I run my practices, you should feel like excited when you see that like I felt about being on your podcast, like, oh yes, I get to see my doc today, right? That's how you should feel, not, oh man, like I gotta go there and they're gonna tell me I'm okay, even though I feel like crap and all that, right?
Or
Like
they're going to gaslight me and tell
or
me it's
they're
my fault.
yeah, I mean, you should
Yeah.
feel happy. You should be excited, and it should be more of a
Like you have a
partnership.
team player.
Yeah,
Like you guys are a
exactly.
team. Like I always say to my patients, like, this is a team effort. Like I'm on your team.
Right.
Like, and I'm not going to prescribe or protocol you up on something you absolutely can't do. Like that's not a team,
Yeah.
doctor for you. As much as I would love maybe a patient, training in the gym 5 days a week, if that's an impossibility, if really getting you to 7,000 steps or 7,500 steps is really the goal, then that's where we start. I'm not just like, hey, no, 4 times the gym a week. Like it's a no go because it's not going to happen.
Right. And maybe it just starts as 10 minutes of walking outside, right? Like you don't have to be so like structured about it, right? Just be outside, breathe air that's not recirculated from your high-rise office building or whatever, right? And just, I think what most people don't do is just continue to have fun. I think, that's a big thing for me is that we have to do at least one fun thing a week with the family and try to bring as much joy and happiness into the interactions as I can, because I think that's, when you feel good, like just like, those wise philosopher Elle Woods from Legally Blonde said, happy people just don't kill people, right? So it's like if you're happy, you just do better. Your cells are happy and you're going to make better decisions about eating and better decisions about sleeping, and you just have to take care of yourself.
I love that. All right, Dr. Sanjay, I know you're not far from me here in
Yeah.
Southern California, but where can we check you out? Where can we learn more about you and the practice? Where would you love us to even be educated more with you?
Yeah, so the easiest place on Instagram, I am Dr. Sanjay MD, so DoctorSanjay MD, because I have an impossible last name. So that would be the best place. Actually, in a few weeks, I'm launching my telehealth practice and starting to see
Congrats.
patients in person as well here in Orange County. So if you're in the hood or if you're in at least California to start, we can certainly set up telehealth, and then it'll be expanding and growing state over state as world domination continues. But I think that there is such a need for functional medicine practitioners in general, but I think in particular, as you pointed out before earlier, there's so few functional integrative cardiologists. We really have to start looking at things differently. And, the benefit, I think, of having someone who's conventionally kind of MDDO trained in this world is because we speak both sides of the equation, we're conversant with both sets of interventions. And, if you're having active chest pain, I'm not going to tell you to do pranayama breathing, right? We need to do a test, right? We need to get that looked
We
at.
need to look at it.
But there are now people that you can go to. I mean, there's not a lot of us, but there are people now that speak both sides of this equation. And that's why it's so important to find someone that you vibe with. And I mean, I'm sure you've seen this, Mariza, too, is that, or Dr. Mariza, whatever I'm supposed to call you is, functional medicine people are like happy people, right? Like I haven't met a jerk once in this realm, whereas in the cardiology universe, it's a very different vibe, right? So, we tend to be
So you're liking the vibe of this crew.
I mean, everyone's community, like everyone is really there, I think, with their heart in the right place to help patients. And I can tell you in my previous practice that I was in, a very conventional practice, a lot of people were just doing things for reimbursement. And that was not a model that I wanted to be a part of anymore. I just want to take good care of good people. Right. And so that's, I think, what this universe allows us to do.
I love that. Thank you so much for sharing that. And it's been such a pleasure. Thank you for coming on.
Oh, my pleasure. If you want me back anytime, give me a holler.
Yes, I feel like there's so much more to explore. So yes, please.
All right. Lovely.
Okay. All right. See you soon.
Bye.
Thank you so much for watching. Now, if you found this video helpful, give it a thumbs up and share your thoughts in the comments. And if you are ready to learn more about perimenopause and how to navigate with a lot of ease and grace, be sure to subscribe to this channel so that you can join our community. Don't forget to share this video with someone that you love, that you know is navigating the perimenopause journey as well, because they deserve to feel their best too. See you in the next video.